I'm so happy that you managed to pass it on your last
Oh,
attempt.
thank you. Yeah, yeah.
Done.
You can imagine. Yeah. I used to find it very challenging when I ask a patient a question like, "Oh, have you had this pain?" And they say, "Oh, 6 months ago or 7 months ago." I didn't know how to deal with that. It used to throw me off. I used to get quite, frustrated because then you have to let them, go on and then, maybe bring them back in. And I used to blame the patient. And obviously, when I did your coaching course, it was quite interesting. I did realize that possibly is how I'm asking the questions. Um, so that skill right there of narrowing it but not making it too narrow um, helped me to get through my data gathering quite in reasonable time. And I think once I was able to do that, then I had enough time to come to the clinical management, bit. I'm an IMG, like I said, English is my first language, but obviously there's little, subtle things in the ways you can say and how you can come across, and even how you know, ask certain questions. So I think that book for me helped me pick up some very good phrases. And then in terms of how the clinical management bit, is presented, it's very easy to translate that to a consultation.
Welcome back to RCA in Focus. In this series, we dissect the strategies, tactics, and tools to help you crack the RCA. I know you've been enjoying the success stories of registrars who've cracked the RCA. Today, we've got a special story. This is a story of Dr Inamuna Beregha. He's an IMG doctor who struggles so much with the RCA. He failed the RCA 4 times and was given one last chance to resit the RCA. It has been interesting to see him progressing and how he actually managed to pass the RCA in his 5th attempt. If you're struggling with the RCA and need help, then book a call with me to see whether I can help you. Click the link down in the description below to book a call with me. Without further ado, let's get right into the interview. Hi Inamuna, how are you doing?
Yeah, hello, good evening, Dr. Kwun. How are you?
I'm alright, thank you. So thank you very much for coming on the channel to share your story. Would you like to introduce yourself for people who may not know you?
Yeah. So my name is Inamuna Beregha. I was a GP trainee in Preston. I'm now working as a GP. I just passed the RCA in January, the January diet. So started working as a GP.
You're telling me that this last attempt that you had in January and that was a last chance. Tell me a little bit about your preparation, because the confidence is probably going to be quite low for somebody who's actually failed multiple times.
Yeah, so that was interesting. I took the first RCA, not the first one, I think the second one in August. I was quite confident because by then I was an SC3. I'd been an SC3 for a while, so I was quite comfortable. So I was confident with the exam, but I felt that maybe it was a little bit premature because I think the pass mark was 143 and I scored 141. So I felt like maybe if I just got in one extra case, then I would have passed, the exam. So that kind of dampened my confidence a lot because I was thinking, okay, where did I go wrong? What was the problem? But I just felt like, okay, if I could just get better cases. So obviously I went for the next exam. That would have been in October, and I think I missed it out by 4 marks again. So, at that point, I think the damage had already been done in terms of my confidence because I was thinking like, okay, can I actually do this? I had two more attempts, and it was very interesting because I never really, I mean, I didn't pass the exam, but the average pass mark has been 143, 144. My score never really went below 5, 6 marks. So I think, at that point, it was kind of difficult to keep recording because I wasn't really sure where I was going wrong. I was taking on feedback, from people who were trying to help me, including my trainer, and I just couldn't nail it. Um, so I think that's one thing that, looking back was also difficult because the RCA, the kind of exam it is, it's psychologically draining. And I felt as I went on, I didn't have the energy, to put into the consultations. So if there's one thing I would say, probably just give yourself time and have a strategy rather than going in blind or trying the exam. Yeah, that's what I would say.
Absolutely. The RCA is more laborious than the CSA because actually have to arrange to get the cases, and recording is quite draining, as you said. So let's take you back to when you were preparing at the time. What do you think were the things that were not working in the previous 4 attempts in Amuna?
If there was one thing that I will change was how I was to actually a couple of things. The first thing was what I thought the examiners wanted. I think I was overthinking it a lot. Trying to be perfect, especially in my data gathering, kind of asking too many questions and just trying to make sure that that bit was quite robust. But then that wasn't giving me the time to have a good management plan. So my preparation, I don't think I was aware of that. I was kind of just fixed on having a good history, and then my management bit was rushed. And then, finally, when I managed to make the data gathering a little bit tighter, I feel I was not really sharing the management. So there was nothing wrong with my knowledge from what I could, see, but I wasn't really sharing it with the patient. Um, and I wasn't responding well to sometimes it feels like patients blindside you to different things. So you have a plan in your head and then they say things. So I wasn't really responding well as compared to, I think, my last attempt. I just took a step back. It took me a longer time to get the cases, but there was one thing I did was I kind of tried to phrase the management in such a way that it doesn't seem like I'm imposing. I know it's a very subtle difference that I didn't really, English is my first language, but at the same time, it's it's very subtle, making it sound shared and just saying, oh, there's this and this and this, which would you prefer, stuff like that. So I had to just go back and prepare those phrases. So I listened to a bunch of my consultations and I saw how I thought I was sharing, but I wasn't sharing it. And, with the help of my trainer, came up with phrases that, made it sound more shared, made it sound like, respected the patient's autonomy, made it sound like I was supporting them in making that decision. And at the end of the day, it felt more shared. So I think those couple of things, the data gathering bit and the clinical management, not knowledge per se, because RC is different from the CSA. I took me a while to realize that because the RCA, you can access knowledge anywhere. Like you can be speaking to a patient and the management plan is there, but it's how you communicate it. So I think that's where I was failing, and I think that's where I made the greatest improvement, and it reflected in the my most recent results.
That's great. Yeah. So, in essence, one of the things that you talk about was that when you first took it, you probably did not have enough time. You didn't give yourself enough time. And
Yeah. So that's one thing that was so important because I think I kept failing the clinical management bit. Not failing per se, but I think my score was in the low 40s. And I feel it's like driving. It just takes time for you to get a feel of it. So if I appreciate that, trainees might, because of their track and when the exam is done, you might feel like you have to rush and do it. But I think still just giving yourself that space mentally as compared to, the putting yourself under pressure, it does help a lot.
that's right. So, tell me about the confidence then. How did you build your confidence back? Because it is quite difficult to go from one exam to another. What did you say to yourself at the time?
I think after my attempt, sometime in, I think that was last year, I'm not sure if it's March or April. I just took a break from actually recording and took a break from the exam because I think before then I was just doing it one after the other because I felt like I was almost there. So I kind of took a break and then I had a feel of just consulting with patients without that awareness that someone is listening to me and just found my natural style. Obviously, when you're consulting, there's always improvements that can be made. I think just speaking to the patient one on one, like putting my attention on the patient instead of trying to meet or satisfy this imaginary examiner that I felt was listening at the corner. I think that helped me become less self-conscious and just to trip over myself. So if there was one thing that, and obviously with the help of my trainer, that helped me to regain my confidence was just talking to the patient in front of me, speaking to them normally without, overthinking. And I think I had a very good rapport with the patient. Coming up with good plans and stuff like that. So it just helped me realize that okay, I'm actually a good doctor because obviously I associated my results with myself. I was still kind of like, okay, I failed the RCH, I must not be a good doctor. So to distancing myself from all of that and then just focusing on the patient for a while, then gradually introducing the recording bit. I know it's easier said than done, but if there's one thing my trainer told me was just focus on the patient. So in terms of my data gathering, in terms of the clinical management bit, I wasn't trying to satisfy an examiner. My interpersonal relationship with with the patient was very natural, and I think that reflected in my results because that was where I scored the highest this time around. So yeah. So if that answers the question, it was just getting back to my natural style instead of this criteria-based consultation I was trying to do to pass the RCA.
It's interesting that you bring that up because some candidates think that they need to go through this checklist approach and they can't have their own styling. And that's one of the things that some people might be confused about. Whereas what you want to be doing is to consult as you would usually day to day and then record that. So tell us a little bit, how did you develop your style, Inamuna, with the consultation? What's your structure like?
So structure wise, I think definitely open questions. What I did was I went back and I looked at consultations where I was making the same mistake over and over again. I'll give you an example. So for example, I'm trying to tell a patient about red flags, and I'm saying, oh, if you have this, and this, make sure you call us back. And the patient is like, oh no, I don't have, I don't have this. So you can see there's just that break in flow and miscommunication. And I noticed that okay, maybe it's happening, time and time again. So it's just coming up with phrases, and obviously I'm not going to give phrases because you can pick yours, what comes naturally to you, but just coming up with a way to introduce that. For example, something simple as saying that I know you don't have these symptoms now, but I'll give you like a list of symptoms or something like that. That if you develop those, that means that this is becoming more serious, and you should definitely get back in touch with us. Or just at different points. So initially, how I opened my consultation was, how can I help you? That was the usual. But obviously, I had to adapt it because I think we're using the e-consult. So it was a case of, oh, I can see you're putting a few symptoms on here. Is it okay if I go through them in more detail with you so we can find out what's going on? And they're like, oh, yeah, yeah, yeah. And then another example of, because I mentioned that I felt like I was being blindsided by many things. And so another example was, apart from what you put on here, were there any other symptoms? And there's a case of, oh, yes, oh, no. If it's related, then I incorporate that. If it's not related, then I say, is it okay if you deal with, something else? So I think that helped me manage is it okay if we deal with it at a later point or after we deal with the initial problem? That helped me keep my structure without forcing things. or without, things coming up in the middle, or I end up ignoring them because they don't really fit in. And that comes across very, 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 doesn't come across very well. So that was one thing, just asking, okay, how can I help you? Was there any other symptom, or was there anything else that we can deal with today? Some patients say yes, some patients say no. Uh, Asking about the psychosocial very early was a game changer for me. Simply just saying, oh, because it's the first time I'm meeting you, is it okay if I just get a sense of your life? Obviously, not like straight after I've asked them, well, how can I help you? But after this, to talk about a few symptoms, just going into their lives and then coming back to their ideas, concerns, and expectations. But I realized that asking about the psychosocial before the ICE helped me to put things in context. And then in my head, when I was asking questions, I was asking questions in terms of impact. If I'm asking about a headache, for example, and I've taken a history of, a headache, and then I'm like, oh, you mentioned you're working, from home. How are you coping with this headache? For example, they say their kids at home. So that just asking about the impact at the same time while I'm taking a symptom history. It could be headache, it could be shoulder pain, because I got the psychosocial earlier on. Oh, you mentioned that. Oh, you work as a carpenter. How are you managing? How are you coping? Really, really helped. If there was one other thing that I felt was quite helpful for me, was the phrases I used to transition from each section. So obviously it was a trial and error, process, but something that came naturally to me. So yeah, structure wise, I opened, then I went, asked a few symptoms, went to psychosocial, went to ICE, then did the red flags bit, which I feel most people are doing, but how you transition, how you are able to manage that bit, because sometimes it cannot be linear. You have to go back and forth. So I'll give an example of what I did this time around. So it was a case of, if I felt someone had back pain or had a fever or anything like that, I would say, oh, it could be a few things. One of them could be an infection or urine infection or something like that. So have you had any burning? Have you had any, stinking? In that way, the patient wasn't answering questions like just in a very open way. So I didn't really, and in a way, I wasn't forcing it or ignoring it. So I was signposting my history very, very well. Like, oh, it could be like, an injury. Have you had an injury? Or it could be this. I used to find it very challenging when I ask a patient a question like, oh, have you had this pain? And they say, oh, 6 months ago or 7 months ago. I didn't know how to deal with that. It used to throw me off. I used to get quite, frustrated, because then you have to let them, go on and then, maybe bring them back in. And I used to blame the patient. And obviously, when I did your coaching course, it was quite interesting. I did realize that possibly is how I'm asking the questions. So that skill right there of narrowing it but not making it too narrow um, helped me to get through my data gathering quite in reasonable time. And I think once I was able to do that, then I had enough time to come to the clinical management, bit. Um, Again, another skill is incorporating what they have said. But all of these skills are basically phrases. That's that's one thing. It's phrasing, how you phrase them, because we all can do that in different ways. But I found a phrase that was quite comfortable for me. Oh, you mentioned this, it could be this. Oh, you said this. Okay, what about this? So I was bringing in what the patient said. How I structured my clinical management page was, I tried to state the diagnosis where possible. Then I explained, then I clarified their understanding if they knew how much they knew. Then I explained, my thinking, and that kind of led on to the options. Like for example, oh, what you're experiencing, it could be, some wear and tear. Explain what that means, and there are a few options to deal with that. Then I pause. So in that way, I was able to, structure it all the way through. But I had to kind of go back and gradually see where I was failing or where I wasn't getting the responses I thought I should get, where I thought I was asking a straightforward question but getting a different answer. Kind of putting it on myself to be like, okay, how can I say that better? Coming up with phrases that I felt very natural to me. Um, so in that way, I was, meeting those criteria without being too conscious of, the criteria. I have to do this and do this, as compared to just finding a way. So it just comes back to finding your style, really.
So it sounds to me that you have done a lot of work on yourself to make sure that you consult in a way that works for you. And this is something very difficult because many registrars don't really know where to start. What would you say would be the best thing to start? How did you go about trying to develop this consultation style that works for you?
I think I always like using the analogy of driving. You with time, you get better with it. Initially, I just recorded not everything, but as much as possible. So I wasn't too picky about what I was recording. But the aim was to find those, I won't call them mistakes, but those areas where it didn't feel natural, it felt awkward. So the skills that so if I'm advising any registrar, the skills that you're already good at, just be confident about those skills. Focus on the areas that you're not good at. I know that it's not, doesn't sound like conventional advice, but if you think about it, because you want a robust consultation for the RCA, it's your weak points that let you down, not your strengths. Your strengths are your baseline. So don't worry about it. Just ensure that, okay, like you're aware of your strengths, but then those areas that you keep falling at, if it's missing red flags, if it's things like that. So for me, I was able to get a lot of feedback. So if I could answer the question, just get as much feedback as possible from your trainer. If the trainer is telling me this consultation is good, it's reassuring, but that doesn't do much for me. So I kind of was lucky. I had a trainer that was very good at giving feedback. So he helped me know what I was good at. So I kind of took my mind off that. So, okay, these are the areas where I'm already good at, and these are the areas where I need improvement. I don't think, apart from feedback, I would have realized that I wasn't really listening to the patients. But by the time I got told that a few times, like, because I had this parallel conversation in my head about these criteria I needed to meet, and over preparing cases, and I had all of these questions I needed to ask, and all of these management options I needed to share. I was trying to listen, but I wasn't listening. So definitely, feedback is where you start from, and then taking on feedback. Sometimes it's a bitter pill to swallow, but there's no point in getting defensive about the areas that you're not good at. So yeah, just ensure that you clarify with, people that can give you feedback. This is what you're good at. This is what you're not good at. And it's the areas you're not good at that let you down. And those are the areas that you need to find a way. And there's no point in someone telling you how to do it. You have to kind of apply yourself and think about how to overcome those barriers. Otherwise, it's not going to come natural to you. But it doesn't really matter. Even if someone tells you how to overcome those barriers, initially it's going to be awkward. Either someone might tell you a phrase, but after a while, it becomes natural. So that's where you start from. Start with feedback. Start with areas that you're not good at. Forget about the areas that you're good at, because you're already good at it. So that's what I would say.
That's a powerful point that you've made, because without feedback, you can actually keep practicing and you're unlikely to make a lot of progress because you don't know your blind spot and you don't know what you need to improve. And having an objective person giving you feedback definitely is very helpful. So now let's talk about your setup when you were recording. Were you recording telephone? Was it face-to-face? Was it audio? What recording were you doing?
I think I was recording mainly telephones, because of time. Initially, it was mainly telephones. Later on, I realized that some cases were quite good to record face to face. For example, cases that had to do with men's health, specifically PSA, prostate exams and things like that. On the phone, it just felt quite vague and unfinished. It didn't feel quite packaged. But being able to examine a man there and then, say that the prostate is enlarged or not enlarged, say that this is most likely irritable bladder because the prostate is clear, like having that conversation. So it took me some time to realize that some cases are good for face to face, some cases are kind of good over the telephone. Pregnant women, mental health, certain cases, IBS sounding cases, some GI cases were quite good over the phone. I started with telephones and then gradually, started recording some face-to-face cases where I had to examine babies, for example. I found it was quite good for me to show my skills. I'll go back to the initial bit. The initial time, I couldn't really see patients face to face. So imagine that, we were all preparing for the CSA, which is kind of a face-to-face exam. And then everything had to switch to telephone. I felt that my natural style was looking at someone, responding to them, responding to their cues, smiling, playing with the kid. So I didn't really have that over the initial bit. So the case I submitted, for example, were submitted more videos than audio. I submitted about 8 videos and about five audios because I found that the rapport was there. I could delve into their lives. I could pick up cues. So there are just some cases that are better that way for video, but wouldn't work. If I had to do a palpitation case or a dizziness case, it's possible, but it's quite challenging as compared to doing that over the phone. There's some other things were quite easier. So yeah, I started with telephones and kind of went on to video. But I think if you find what's natural to you, some people pick cues very well over the phone. I don't because I can't see the person's face. That was a big challenge for me.
So, with regards to your practice, then sounds like your educational supervisor was very supportive. Did you actually change practice during this period when you were doing your RCA?
Yes, I did. I did change practice. I think on my last attempt, I had to change practice. Yeah.
Could you tell us what were the things that help you to get cases in your practice? Because I understand that you have moved to different practices and you have experience working in various practices during the RCA.
Yeah, absolutely. So the new practice I was at, they had a different system, which is the e-consult, where the patient fills in, as much details as possible. So I think that was a very, it put me at a very big advantage because I kind of knew a lot about, what they were presenting with because they put a lot more detail as compared to previously that it was just a case of, someone presenting a headache, with the Accurex forms, someone can put a lot more detail, their concerns, their expectation, things like that. So I think it's not like there was anything wrong. It was just a system. But yeah, I did prefer the fact that I could, read the e-consult, and that helped me when I was going through the patient's letters, for example, know what to read about, know what to prepare. It just helped the anticipation. So I wasn't really blindsided by things. So if I could give an example, I came to a point where if I saw, a problem, I kind of went from, the end of the case that I thought in my head to the beginning. I was able to anticipate better. I was able to read the patient's notes, know about allergies. If I knew I was gonna be prescribing a cyclovir, for example, I was gonna check, okay, is the patient on any other medications? Do they have any, organ failure? It just helped me anticipate better. I know it's a current theme. I've said how I felt blindsided. I wasn't responding well to, so this is a real life patients going off on tangents. I didn't really respond well to that, but I think with that information on the e-consult, I was able to prepare better for the cases. I know that many trainees wouldn't have the advantage, but it's difficult to answer that question, obviously, as you can see, because it depends on where you are. If there was another thing that helped was that my supervisor was the one booking the cases for me, so my list was, I basically had my pick of cases. Again, if you're somewhere that's how it works, then that's an advantage. But I think it's about just having a conversation with your trainer, and seeing even if it's 3-4 cases that they can book on your list, it's going to make a world of difference.
Could you share with us what recordings did you end up submitting for your fifth attempt?
Yeah, sure. So I think I had a case where a patient had dementia, an elderly patient. So that was my elderly case. I was able to explore about the current issue and also about the psychosocial. So that was one case. I also had a case of baby reflux. I think the challenge was there because of the parental demands, in terms of what the guardian says and what the parents was demanding. So that challenge was there. A simple case I submitted was a child with an upper respiratory tract infection, and then it was a case of antibiotics or not. I was able to dig into the past medical history and understand why that demand for antibiotics was there, and then use it in the clinical bit. There was a pregnant lady with depression, history of postnatal depression, discussing antidepressants, the benefits and risks on the baby and things like that. Then there was another case I had a few mental health cases. I think those were the cases that I recorded on the phone. Quite a few mental health cases. Didn't really have much of men's health. It was, for the criteria, which was elderly. So I've spoken about the elderly, I've spoken about the children. I had a case of some joint problems affecting a kid that played sports. I think it was Oshkood Schlatter. I think what I would say was a couple of my cases, I had a feedback where they said it wasn't really suitable for the ROC in terms of showing, the skills that were required. I can't really say for sure which cases they were, but I didn't fail any case, if that helps. So even if they weren't at the standard of the RCA, they still passed. I may have scored lower, but they still passed. So overall, it was a good mix. Most of the children, most of the I would say physical problems, chest pain, things like that, were face to face. But for the mental health bit, anxiety, my woman's health, because it was also a mental health issue, was over the phone. So it was a good balance.
That's right. So in terms of your acute case, do you remember which case did you submit?
I think my acute cases were a couple of cases, 2-week rules. One was a dysphagia who just wanted antibiotics. So I was able to negotiate, explain, and then it came to that point where the patient kind of understood the risk and accepted the referral. So that was the acute case. It wasn't just a case of, oh, you're going into hospital. I think that was my most challenging case, the acute, because I know it's easy to score very low there. Even if they've said, oh, it doesn't have to be complex, you don't have to do all of these things, it's quite easy to score low if you just say chest pain, hospital.
That's right, yeah. So there was a layer of complexity because of the demand of the patient there.
Yeah, yeah.
Do you remember your long-term condition?
So the long-term condition, I think the dementia was part of it. So it was a flare-up of a long-term condition. I think I just had to discuss, why the patient wasn't on certain medications because of, so it was elderly and long-term in one. Um, so why the patient couldn't tolerate certain medications to treat their long-term condition because of their comorbidities. So in that way, the complexity was reasonable, because of
Right.
because of the case. Yeah.
So that's very good. You've managed to get a selection of telephone consultation and then video recording. When you were actually selecting which one to submit, which one is not going to make the cut, what was the process? What did you do differently this time?
I think I picked those cases that had, I know this is quite subjective, but had a very good flow. If because I had quite a good case bank, but if I felt a little bit like it wasn't clear what was going on in an aspect of the case, if I felt weird, if I felt off, then automatically that was gone. Because if I feel that way, the examiner is going to feel that way. So obviously, I know a lot of people are going to tell you the technical details of it, but I'll spare you all of that. So I went with cases that felt had a good flow, had a good rapport, felt shared, where the patient felt satisfied at the end, that had a very good closure, had a very good rapport from the beginning to the end. Cases where I delved into, the patient's past medical history, picked up something that could have been easily ignored, things like that. So that did it for me. But because of my past experience of the clinical management bit, that's what I'm referring to. I just ensured that it was shared. Ensured it was shared. I wasn't too fixed on how complex it was. So I just yeah, exactly. And also if there was a clear diagnosis, that was another criteria I used. So if it was a case of dementia, reflux, could this be pyelonephritis, are we dealing with sepsis? That was something that I ensured that it was clear. I had made a diagnosis and it wasn't vague. That's what I can say. Obviously, before I got to this point, I had already used the RAG rating to, mark the cases. But in terms of selecting the cases for the exam, I was very big on rapport, flow, that nothing, I won't say nothing, but avoiding cases that had a lot of doubts and at the back of your mind, you're not sure what's going on. Like this could have been this, but it could have been something else. I avoided all of that. I picked a very clear diagnosis, and a very good closure. So even if it didn't start very well, but they had a very good, nice, ending to it.
That's very useful to hear from you because I understand that your interpersonal skill domain was the highest you got. Would you be able to share your score for people to learn about what score? Because this time you actually managed to score with a good margin.
Yeah, yeah, absolutely, absolutely. I think my interpersonal I scored a 59, I think, a 59. It didn't really change much from previously. I think previously it was about 54, 55, but I scored a 59 now. The clinical management bit was the area I improved the most. So for example, I had a 50, but I think previously it was about 41, 42. And then the data gathering bit was about 55 or 54. I had 164. That was the mark I got now. So while I was on the border, before now, I had a reasonable margin.
What resources were useful to you? Because I know that your educational supervisor played a very important role. What other resources you found useful? People who actually have failed the RCA and don't really know what to do different. What would you advise them?
I think the CSA Symptom Solver. No, there are two books. There's a Symptom Sorter and Symptom Solver. The CSA Symptom Sorter and the CSA Symptom Solver were two books that I wish I had the Symptom Solver at the beginning, because of it. It can help you take a very focused history. Obviously, if you at this point in everyone's training, it's we would know what to ask and what not to ask, but it just helps with the phrasing. I'm an IMG, like I said, English is my first language, but obviously there's little, subtle things in the ways you can say and how you can come across, and even how you know, ask certain questions. So I think that that book for me helped me pick up some very good phrases. And then in terms of how the clinical management bit, is presented, it's very easy to translate that to a consultation. And then with the symptom sorter, when I looked at the e-consult, I was able to pick up 2 or 3 differentials that I could explore in the consultation. If there was one thing that both of the books helped me to do, was while in the past I used to talk about the differentials and the clinical management bit, I was able to do that in the data gathering bit. So, the part of the criteria that says, explores differential. So instead of having a long-winded explanation about differentials in the clinical management bit, I was able to, take the history and include or exclude this diagnosis. So while I was in the clinical management bit, it came across as I was very confident in the conclusion or the diagnosis I'd come to, because I was exploring these red flags and other differentials in much detail into the data gathering bit. So again, that helped me just package my clinical management a lot better.
Yeah. So you managed to tease out what it's not and have a clear idea what it is from your focus history. And then you were able to commit to working diagnosis and have a good plan. Regarding the coaching, then, this is something that you mentioned. Why did you think that you needed coaching?
When I was discussing about those areas where you're weak at, it was one area in terms of taking a focus history where I was faltering time and time again. So even if I was, like I said, you have to go within yourself and try and figure out how to overcome these challenges, but it wasn't something I was doing successfully on my own. And I think I'd seen your videos on YouTube. I had been just using them, listening to them. I think a colleague of mine also in my training program, you know, went through your course, and I think I saw the interviews and things like that. And I think she found it quite beneficial. So I decided I was going to just, have coaching on that alone. And I can say that by the next couple of weeks, I was, I think my confidence skyrocketed because I could take the history in a reasonable time. Then I had all the time to do clinical management. So that was something I had to go outside of myself to kind of, seek help, get feedback on, practice. And that was quite useful for me.
Did you have any hesitation or any thought that this might not be useful?
No, not really, not really, because I've had coaching for other things in my life, other areas. Coaching is actually a regular part of, like, at the beginning of the year, things like that. I meet with the coach just to see where I'm going. But I'd never done it for work or like consultation skills like this. So I knew it was going to be beneficial for me. I think the only reluctance was if it wasn't free. So but I realized that I needed to you know invest in myself, to put it that way. Yeah. So it wasn't a reluctance. It was just like I just had to do it.
So now that you're working as a GP, looking back at the RCA, do you think that the work that you put in and your preparation is helping you in your day-to-day activities?
100%, 100%. I feel like I feel like that process prepared me, to be a GP. I'm not finding certain things quite challenging as I thought I might have, possibly because for the RCA I had to go in depth and do it over and over again. So certain skills have just been reinforced in me, through that process. So I don't regret the process. Could I have done things better? Yes, but I don't regret it because of the doctor I am today. I feel like it's worked to my good.
Now that you've passed the RCA, and having reflected on your preparation, if you could go back and have a chat with yourself when you were preparing for the first attempt, what would you have said to yourself then?
Well, I have said that just be natural. Be natural in your style, be natural with the patient, kind of focus on the patient. Don't really think about all of these, criteria at the back of your head. It doesn't really serve you. Find a natural way to consult, explain things, have that connection with the patient, and it makes a world of difference. And don't be in a hurry.
Thank you very much for sharing your story, Inamuna. I've learned a lot from your journey, and it looks like patience, perseverance, and the work that you put in has paid off. And I'm really happy that now the RCA is something that's in the past for you. You don't have to do any of this. If you have been struggling with the RCA and have realized that doing it on your own might not be the best use of your time and resources, then book a call with me to see whether I can help you. If I can help you, then we can enroll you on the one-to-one coaching program. But if I can't, then at least you'll get some insights in your preparation. Click the link down in the description below to book a call. Take care, everybody. Bye-bye.